Good morning, everyone. I'm Dr. Jyotsna Jarida, and I'll be discussing few cases for interpretation and analysis of visual field. No financial disclosures. My first case is a 43-year-old male who was diagnosed as glaucoma suspect somewhere else, however, was not started on an AGM. He has no family history of glaucoma, no history of any systemic illness. On examination, his best corrected visual acuity was 6.6 and N6 in both eyes. Applanation tonometry adjusted for central corneal thickness was 16 millimeter of mercury in right eye, and in left eye was 14 millimeter of mercury. On slit lamp examination, both eye anterior chamber was found deep, and on gonioscopy, both angles were open. So this is the fundus photo. The right eye optic disc was slightly larger, cup disc ratio was 0.6, and there was a parapapillary atrophy present. In left eye, cup disc ratio was 0.7, parapapillary atrophy. So we made a diagnosis of glaucoma suspect both eye. So now when a patient with no family history, best corrected visual acuity 6.6, intraocular pressure 16 and 14, whether should we start treatment or not for this patient on the basis of looking at the optic disc. So we did OCT next. OCT was found to be both eye normal. We did visual fields for both eyes. In right eye, visual field was normal. In left eye, we could see that there was nasal step, nasal depression was there, and we could see that there was paracentral scotoma. So again, we magnified we saw the dilated fundus again of the left eye, and we could see that there was initial RNFL loss presenting in superotemporal quadrant. Can you see this? So even though the OCT was normal, optic disc NRR was looking normal, but there was superotemporal thinning was present, which was also visible on red-free photograph. So which was the defect which we could see on superotemporal quadrant. It was similar to what we could see in HVF. So now we had started the patient on treatment, even though the disc and NRR looked normal. So my second case is a 50-year-old male who presented to us in March 2025. He had a chief complaint of blurring of vision in both eyes since 6 months. He was both diabetic and hypertension, hypertension, and there was a raised systolic blood pressure was documented for him. Best corrected visual acuity in right eye was 6.9 and left eye was 6.6. His corneal thickness adjusted IOP was 16 and 17. On slit lamp examination, anterior segment was normal and anterior chambers was deep. Gonioscopy was done and both eyes angles were found to be open. So this is an undilated picture. We could see in right eye the average size disc, cup disc ratio of 0.6. NRR looked healthy. Inferior rim was larger than superior rim. In left eye, we could see that the cup disc ratio was of 0.7. Parapapillary atrophy was present. So we made a diagnosis of glaucoma suspect for both eyes. So again, the same on the basis of looking at the optic disc, should we start treatment or not for this patient? We went ahead with OCT. There were changes in right eye OCT. Left eye also showed changes. We did visual field for the patient. In right eye, we could see that there was temporal scotoma, which was respecting the vertical midline. And in left eye also, there was vertical scotoma, which was respecting the midline. So when we dilated the fundus and we saw, in left eye, there was cup disc ratio 0.6 with slight temporal pallor was visible. So a diagnosis, we could see in visual field, there was right homonymous hemianopia. MRI brain was suggested to the patient, and there was found to be a hematoma present in his brain. So my third case is a 58-year-old female who had come to us for second opinion of cataract surgery. She was both diabetic and hypertensive, and there was no family history of glaucoma. Best corrected visual acuity was 6.12 and N18 in both eyes. Applanation tonometry adjusted for corneal thickness was 19 millimeter of mercury and 20 millimeter of mercury. On slit lamp examination, both eye had immature senile cataract of NS grade 2, and on gonioscopy, both eye angles were open. This is an undilated photo. Cup disc ratio, disc appeared to be large in right eye with cup disc ratio of 0.7, inferior rim thinning. In left eye also, cup disc ratio was large with cup disc ratio of almost 0.6. So we made a diagnosis of both eye immature senile cataract and glaucoma suspect for the patient. We did the visual field for the patient. We could see in right eye there was superior hemispheric changes were present. Left eye was more or less like a learning curve. Then we did 10-2 for the right eye, since there were changes in right eye, which was involving the center. So when we did 10-2, we could see that there was split fixation. OCT in right eye, there was inferior thinning, left eye was normal. So when we dilated the patient and we saw, we could see that there was optic disc pit present in the inferotemporal quadrant. But since in visual field there were changes which was involving the center, cup disc ratio was large, we had started the patient on medication. That's it. So my take-home message is investigation in glaucoma plays a supportive rather than a primary role in diagnosis. The mainstay of diagnosis relies on a comprehensive clinical evaluation, including patient history, symptom assessment, and a thorough examination of the optic nerve head. While visual field testing and OCT provides valuable supplementary information, they are corollary to the diagnosis and are used as support clinical finding rather than establish the diagnosis on their own.
Thank you, Dr.